Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. 50 years ago, pediatric rheumatology didn't really exist. Not as a system, not as a field, not as a coordinated effort to care for children with complex inflammatory diseases. Now, the patients were there, the diseases were there, but the structure around them wasn't. Children were treated across many different specialties, often without the tools, therapies, or shared understanding needed to change outcomes. Disability was very common. Treatment options were very limited, and the expectations were remarkably low. In 1976, a small group of clinicians and scientists decided that needed to change. What followed wasn't just a new subspecialty, it was a rethinking of how we understand immune-mediated diseases in children, how we organize care, and what outcomes we consider acceptable. Today, many children with juvenile idiopathic arthritis and other rheumatic diseases can expect remission, as our therapies, including biologic therapies, have really reshaped the treatment landscape. But the deeper question is not what has changed over the last 50 years. It's what made that change possible and where the limits of that progress still are. My guest today is Dr. Ekemini Ogbu, a pediatric rheumatologist and physician scientist at Cincinnati Children's Hospital Medical Center and the University of Cincinnati. She's director of neuroinflammatory disease services in rheumatology, co-director of the Lupus Center, and chair of the American College of Rheumatology Committee on Pediatric Rheumatology. This is a conversation about how a field gets built and what it takes to move it forward. Enjoy. Ekemini, welcome to the show.
Thank you. I'm happy to be here.
So I'm super excited to talk to you about pediatric rheumatology. This year, we're celebrating the 50th year of sort of what we're calling the founding of pediatric rheumatology. It's still a small field, and I'm always interested in how people got to know pediatric rheumatology and became pediatric rheumatologists. So I was wondering if we could spend a few minutes talking a little bit about your history and how you found pediatric rheumatology.
Definitely. So my journey to deciding to be a pediatric rheumatologist wasn't quite straightforward. I'd say like in med school, as in like most other people, the exposure to pediatric rheumatology was not really there. We would learn about rheumatology in the internal medicine part of things, but even then, it was just a small degree. But when I became a pediatric resident, I found myself being more attracted to those diseases that were rare and really complex, and realizing that because they were rare diseases, patients felt isolated most times, and helping families navigate a new diagnosis was quite challenging. So I realized I was really drawn to those type of cases, even in the emergency room, when patients come in with a flare. Apart from seeing other patients that needed procedures, I would take my time with these patients that were often very complex. So it wasn't until the end of my first year as a resident, my intern year, that I realized that that's probably what I wanted to do. So my residency was at Children's Healthcare of Atlanta, Morehouse School of Medicine. And most of the rotations at, say, the inpatient service, we would have a lot of pediatric rheumatology consultations. And so from there, I got more exposed to the disorders that we could see. I got to know some of the pediatric rheumatologists, and they were really, really nice people, very knowledgeable, very approachable, and so passionate about what they did. That was the faculty then at Emory University, Dr. Prahalad Sampath, Kelly Rosta Stevens, Sheila Angelis Han at the time. But meeting them made it so easy to see myself in that capacity. So I did a rotation with them, absolutely loved it. And the rest is history. I applied for a fellowship with them, and that's why I did my training. And so that's how I came to pediatric rheumatology to practice in that space.
Yeah. I feel like those early mentors make such a big difference in selecting the specialty. So I had a similar experience with some awesome mentors early on that made me want to become a pediatric rheumatologist. It's been great. I was wondering if you could take us back 50 years. So we're saying that pediatric rheumatology in the United States has been around for about 50 years. But kids with rheumatic diseases have been around for much longer. So a child with what we call juvenile rheumatoid arthritis back in the day, or Still's disease, or any one of these things, who was taking care of them? How were these people receiving care?
Children with rheumatic diseases have existed a long time, for centuries now. And it wasn't until much more recently that we realized that a subset of pediatric patients which we need to pay more close attention to. They were being taken care of pediatricians, some adult rheumatologists, orthopedists, and different specialties before specialty was formalized. Prior to the formalization of a specialty in 1976, there were people that were sort of trained and exposed to pediatric rheumatology, and we're taking care of patients as well. But there were only a handful of those. The rationale behind having that 1976 meeting was to try and formalize things, try and see where we stood in taking care of this vulnerable population. But you're right, the diseases have long existed. We were just catching up to how we could do things a little better.
Yeah. And I think you mentioned that meeting, I think in 1976, what was called then the American Rheumatism Association, which is now the ACR, had the first conference on rheumatic diseases of childhood in Park City, Utah. Why do you think there was a need to sort of define pediatric rheumatology? Why wasn't it enough for kids to be taken care of by adult rheumatologists or orthopedists or their pediatricians? Like, what was the urgency to sort of create this particular specialty?
I mean, overall, at the time, pediatrics as a field on the whole was trying to hone in on different subspecialties to take care of kids with various disorders in a more enhanced fashion, so to speak. We were one of the latecomers to the show, the Pediatric Rheumatology Group. But then again, remember that rare diseases are so, at least in the rheumatic space, are pretty severe and complex. And we didn't feel we had the right outcomes at the time. We did not have as much research as we would like. We did not have as much therapeutic options as we would like. We wanted to see how to make things better in the care of these patients and how to improve access to care was part of the things. How do we take care of kids that they do not have to end up being wheelchair bound? How do we find a dedicated group of physicians and scientists that would help to move the science forward, help to drive education because we needed to train another generation and just keep things going in such a phenomenal forward trajectory. So I think that was the thinking behind having the meeting. Children are not little adults, as we know, and same goes to why we have pediatrics as a field. The physiology in childhood is different, and it differs by age, certainly. Some of the diseases are more common in childhood than in adults. In rheumatology, we know many of the autoinflammatory syndromes, the monogenic diseases, are more common in pediatric populations. So it became really necessary because we did not only have non-inflammatory musculoskeletal concerns, which orthopedists would be helpful in, but we had all the inflammatory conditions. It was beyond just immunology or immune deficiency, but there's like a whole spectrum of other disorders that we weren't quite taking care of appropriately. And so that was the rationale for having the meeting in the first place, just the need to get more organized in how we could do things better.
Can you talk a little bit about how a child, what was the treatment like in a child with juvenile rheumatoid arthritis? You mentioned wheelchairs. I mean, now, if we have a patient, in 2026 with JIA that requires a wheelchair, that's big failure, right? but that was much more common back in the day. So what tools were available to physicians taking care of these patients?
First of all, we changed the name from JRA, juvenile rheumatoid arthritis, to juvenile idiopathic arthritis, and have subclasses under that currently. But that was one of the ways we were able to better, identify the disease. In terms of the therapeutics at the time, for the most part, we had steroids available and nonsteroidal anti-inflammatories initially, so much so that the early clinical trial that was run by the Pediatric Rheumatology Scientific Collaborative Group, the PRCSG, was on NSAIDs, steroids, methotrexate. Those were really a long time ago.
Wow.
And that was one of the main clinical trials we had at the time. But before that, with steroids, which was kind of the mainstay of therapy, and NSAIDs, they can only do so much. Steroids in particular have really damaging side effects long term that we would like to avoid. So there wasn't really much in terms of therapeutics. Of course, there was gold, where patients would have gold injections as well. At the end of the day, we found out that gold was not very effective. So we didn't really have much at hand at the time. And so when patients would have really debilitating forms of arthritis affecting their fingers, their toes, their knees, they would end up with contractures, they would end up being wheelchair bound. It was pretty common to have like an arthritis camp where you have kids come in a more laid back atmosphere for networking and just camaraderie, to have most of them come in wheelchairs at
Wow.
the time. And so when you look at the pictures from back then and you compare them to what the arthritis camps look like today, it's very, very different. So we have certainly advanced in the availability of therapeutics and the effectiveness of those medications.
Great. You mentioned a research group doing, some of the early studies. What other groups have been sort of responsible for moving the field forward? The ACR seems to have been sort of big group that got people together and got people excited to talk about the field of pediatric rheumatology, but what other groups have been important in the creation and the advancement of pediatric rheumatology?
The American College of Rheumatology has spearheaded a lot of the collaborative efforts and advocacy, but also worked with the Arthritis Foundation, which we all know pretty well. Even in the initial meeting, the Arthritis Foundation and the Shriner Group was also part of the co-sponsors of that initial meeting. In the early 2000s, within pediatric rheumatology, the Childhood Arthritis and Rheumatism Research Organization, CARA, was formed to help bolster pediatric rheumatology research, collaborative research. And CARA, the emergence of CARA has been really fantastic and has pushed our specialty in really amazing ways in clinical and translational research. So it's a major network, the largest network of pediatric rheumatology centers in North America, and with some sites outside North America, but predominantly within North America. Currently, I believe there are probably up to 90 sites that are part of CARA. It holds a longitudinal registry and much more. In that space, pediatric rheumatologists have been able to work in work groups targeting various diseases, targeting cross-cutting themes. And what's really special and unique about CARA is the close involvement of the patients and the families and the caregivers. So much so, a lot of the research is very patient-centered, very patient-driven. And it's been such an amazing network that has even pulled younger pediatric rheumatologists into research in the field. So then we also have the PR Coin network, which was started more recently, that does quality improvement and now more implementation science research. It's a smaller network of sites, but also they are helping to advance quality of care at the bedside and looking at ways to do that using the EMR and other technologies. I talked about the PRCSG already. Most of the drug approvals for biologic medications in the US has been really through the supportive work of the PRCSG. It's a network that has over 60 sites or so, and it's the oldest of all the pediatric rheumatology research networks. They, in conjunction with pharmaceutical companies, run clinical trials or coordinate clinical trials with colleagues in Europe as well, the European group also. So, really, those organizations have all brought different aspects to making pediatric rheumatology as great as it is of a specialty currently.
Amazing. Can you talk a little bit about how you've seen the field change since you started practicing? What have been some of the breakthroughs or changes that you've seen even within your career?
Really, the first thing is just the availability of biologic therapies for children with rheumatic disease, particularly juvenile idiopathic arthritis. When I started, we were just looking at mostly Humira and then Enbrel and perhaps infliximab. But since then, there's been such an explosion of available therapeutics. Now we have some biologic therapies available for children with lupus, which for the longest time, systemic lupus, we had struggled to get approval for medications for that disease, so much so most of treatments were used off label. And now we are in another era where we're exploring CAR therapies in pediatric rheumatology. And so it's a very different landscape than when we read the history of rheumatology, how we started and where we are now. Another thing is just the type of practices and a model of care options that are available to families now, where we now have a lot more disease specific programs. Many clinical sites have dedicated disease programs, whether it's for lupus or lupus nephritis, neuroinflammatory conditions, vasculitis, or myositis. Some have rheumatology, dermatology clinics, and all this kind of multidisciplinary integrated models of care, which is really amazing and is helping to improve patient access, collaboration, research, and care, and access to even clinical trials. That's a different landscape. And certainly, there are a lot more pediatric rheumatology centers than when I started, as well as more fellowships. I could go on, but definitely it's just so much growth that even in my time in the field, I've witnessed so much growth already. And I can imagine for those that have been practicing for decades, what that difference looks like. It's amazing.
I'm wondering if you can talk to us a little bit about, you mentioned all the progress that pediatric rheumatology has gone through over the past 50 years. Are there still some children that aren't benefiting from these advances? Are there some limitations in access to care and cost of medications? Can you talk a little bit about that?
Right, you're right. We've made advances, but we still have places we continue to work on. Certainly, access to care is one of those where we know that there are still several states in the US that do not have even one pediatric rheumatologist. And we know that there are several states that have two or less, in fact, just one pediatric rheumatologist, which is grossly inadequate when we think of the population and the epidemiology of some of the rare diseases. In essence, we know fully well that some patients are not being cared for just because there are not enough of us. And so that's a challenge and something that for the past decades there has been uh, ramping up of advocacy and collaboration to try and move the needle, so to speak, where we are trying to address those access to care issues by helping our colleagues that want to go and start practices in those settings, helping them with tools to be successful, helping programs that want to expand the kind of services they have to underserved areas, thus helping to support that. So we definitely have room to improve access to care. And it's not something that is only unique to pediatric rheumatology in this pediatric subspecialty space. But for us, it's even more important because we deal with rare disorders and the kids we take care of and young adults tend to have very, very severe illnesses. So it's a critical area that we are focusing on.
I wonder if you could, bring us to today. Maybe talk a little bit about everybody's talking about artificial intelligence. Was wondering if you could discuss if that is being used in your practice in the field of pediatric rheumatology or in general, and maybe make some predictions about how you think the field will evolve over the next few years.
Artificial intelligence has been there. It's just we're trying to use it in different ways, make the algorithms work better. Where it's been very useful, I would say in my practice and in several other practices now that are adopting this, is in the bedside interaction with the families where we have some of these tools to help with note taking and writing and things like that. In synthesis and diagnostics, we haven't really started using that in the clinical space. Certainly, we have artificial intelligence in the research space where we're using it for neuroimaging studies. We're using it in different ways, using it for large epidemiological studies as well. I do see us using AI and machine learning algorithms even more, particularly as we become very more creative in trying to understand our diseases. We have better tools at our disposal, so much so that we have more precision-based approaches to taking care of our patients. And just having AI in that space with advancing research would help to move things forward. It's still emerging, certainly, but at least for now, we use AI for our notes and in trying to alleviate some of the burnouts, high risk burnouts processes that we have.
And then over the next 5 to 10 years, how do you think the field of pediatric rheumatology will change? How do you think we'll be taking care of kids with JIA 2030, 2035?
First of all, I think if we are able to improve our access to care, we'll have more patients being able to access services. If we're able to modify our access to care, would also have patients being seen in a more timely fashion. We're having more fellows coming into the field. But we also have a challenge where a number of our current clinicians would be retiring as well. Something we have to think about, but I do think if we are very intentional in our models of care and addressing access to care, we would be able to really improve the way patients can access their care to rheumatology. I think in terms of therapeutics, certainly every day we continue to have clinical trials. And so we have continue to have more options in biologic, non-biologic therapies. I know you spoke about juvenile idiopathic arthritis, JIA, but there are other diseases that we take care of that even very severe and have high risk of mortality and morbidity. Things like lupus, juvenile dermatomyositis, systemic scleroderma, and things like that. Even in that space, there will be clinical trials. There are CAR therapy trials going on. And so definitely, I think the therapeutics that would be available would be a bit different from what we see today. I think it can only get better in that domain. I think we're really organized, with CARA, with PRCSG, and Paracoin just being able to track long-term outcomes in rheumatic diseases that would inform even more things that we can do, how we can implement change in our practice habits, implement change at system level in our institutions that would improve the care that we give. Again, I only see us becoming more sophisticated in our practice. I see us being more sophisticated in the therapies that we provide.
I think you're right. Like being able to deploy our knowledge to take care of wide variety of patients, I think is still a big challenge, right? Even if we know how to take care of kids with JIA or lupus,
Mm-hmm.
is delivering that care to that patient in rural states that needs it, or identifying these patients early before, they accrue damage. I think it's still hopefully a solvable issue, but certainly still a challenge.
Uh-huh.
What do you think gives you optimism about, the next 50 years of pediatric rheumatology?
I think it's because we have an emerging generation. We have really young pediatric rheumatologists. Yes, we know that we do struggle to attract more fellows into the field, at least as much as we would like to. But I'm optimistic that we have a vibrant young generation that is learning and will be able to continue the good work that was already started by our predecessors over 50 years ago. And I think that with working in concert with the regulatory bodies for education, such as the American Board of Pediatrics, the ACGME, we will be able to really increase, hopefully, the number of pediatricians, residents, or people interested in pediatrics in general and in pediatric rheumatology with time. So I'm optimistic that that would happen. I know it might not happen overnight, but eventually it would happen. We just have to be intentional about it, and that's what makes me optimistic. I think we have a bright future for our patients. I'm excited in particular for the kind of things we can do to help our patients. I think that's what keeps us going.
Yeah, great. We talked a little bit at the beginning about our mentors and how those early mentors were important for our decision to become pediatric rheumatologists. And I hope that people that are listening to this podcast may see you as a potential mentor in the future. Certainly, all the work that you've done in pediatric rheumatology has been amazing and inspiring. And, I hope that you continue taking care of patients and discovering new treatments and new pathways in pediatric rheumatology that can help improve the care of our patients. Ekemini, I thank you so much for your time and for all the hard work that you've done.
Thank you. Definitely. Thank you. And yes, we're appreciative of our mentors, and our community is so close knit where people can trace their roots back. We're still that small, but we're still mightily impactful. That's how we put it. So definitely history, we still have history, word of mouth, handed down, passed down. And I think that's a privilege. We're a privileged set of clinicians, I think.
I couldn't agree with you more. Have a great one.
You too. Bye-bye.
What this history makes clear is that progress in pediatric rheumatology was not inevitable. It was constructed through collaboration, trial and error, and through a shift in what clinicians were willing to accept for their patients. Outcomes improved because expectations did. But that progress is still incomplete. Access to pediatric rheumatology care remains uneven. Entire regions still lack pediatric rheumatologists. At the same time, the field is entering a more sophisticated phase with earlier treatment, more targeted therapies, and more integrated care models. Pediatric rheumatology has advanced rapidly, but it still hasn't reached everyone who needs it. The next 50 years will depend on continued discovery, as well as our ability to deliver that care to the children that need it. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, give a hug to your closest pediatric rheumatologist. And of course, stay healthy.